know, because in the exams, somewhere or the other, we always ask you practice guidelines. Guidelines means, of course, they are guidelines and not protocols, but that is how to guide us practice our daily routine cases. So, Veena, thanks a lot, and please start the lecture.
The topic of my discussion is practice guidelines for obstetric anesthesia. So the main objectives of my talk are overview of maternal physiology as relevant to the anesthesiologist, anesthesia concerns in the parturient, what are the recent changes in clinical practice, managing difficult airway in obstetric patients as per All India Difficult Airway Association guidelines, and post-operative pain relief. So I will be giving you some overview of the major physiological changes that occur in pregnancy. Almost all the changes seen are due to the high levels of progesterone, and they include 35% increase in total blood volume, 40% increase in the cardiac output that occurs due to increase in the stroke volume, and increase in heart rate, which increases by 15 beats per minute. There is decrease in systemic vascular resistance, and that occurs in the second trimester. There is increased blood flow to the uterus, and due to in the supine position, due to aortocaval compression, there is decrease in venous return from the legs. So as we see in this diagram, that there is cardiac increase in the cardiac output, stroke volume is increased, heart rate also increases by 15 to 25%, intravascular volume is increased, and there is 20% decrease in the systemic vascular resistance. There is minimal change in the systolic blood pressure, whereas diastolic blood pressure decreases by 20%, and the decrease is at the mid-pregnancy. The blood pressure, diastolic blood pressure comes to the pre-pregnant values at term, while the filling pressures like central venous pressure and pulmonary pressures, they are unchanged. Oxygen consumption also increases in pregnancy by 30 to 40%. So due to the changes in the cardiovascular system, patients with pre-existing cardiac disease may decompensate very rapidly in labor or in the immediate post-delivery period, as this corresponds to the time of the maximum increase in cardiac output. Approximately 400 to 600 ml of blood loss occurs at delivery during the normal vaginal delivery, and the blood loss may be increased up to 1 liter in the cesarean section. As we can see in this diagram that the supine position causes the abdominal compression by the gravid uterus, and the supine hypotension syndrome occurs. Whereas when we put the patient into the lateral left decubitus position, there is a relief of the aortocaval compression. There is increase in oxygen consumption by 20% in the pregnancy, whereas the oxygen consumption is increased almost to 100% due to the increase in the metabolic rate and due to the contraction of the labor pains. There is increase in minute ventilation by 50% due to the rise in tidal volume and the rise in the respiratory rate. There is decrease in arterial PCO2 levels. The PCO2 levels in pregnancy are 28 to 32 millimeter of mercury, whereas if the PCO2 levels are 40 millimeter of mercury, that indicate the onset of the ventilatory failure in pregnant patient. There is decrease in the functional residual capacity, causing a decrease in oxygen reserve. Uptake of inhalational agents is faster in pregnant women. Decreased functional residual capacity and rise in the oxygen consumption increases the risk of hypoxia with apnea. Like apnea when we are doing the tracheal intubation. So these patients, they desaturate very rapidly. Pre-oxygenation prior to general anesthesia is also less effective. Like these patients, they desaturate very rapidly during the attempt of tracheal intubation. As we can see in this diagram that there is flattening of the ribs also due to upward shifting of the diaphragm. There is venous engorgement of the airway mucosa, edema of the leading on to edema of the airways, worsening of the Mallampati score in labor, and this leads to trauma to the upper airway with suctioning and with intubation. And there is increased incidence of difficult or failed intubation in the pregnant woman. So it is necessary to keep the required difficult airway cart ready when we are giving general anesthesia or regional anesthesia to these patients. So there is decrease in minimum alveolar concentration by 25 to 40%. There is decrease in dose of local anesthetic requirement for regional techniques by 25 to 30%. And there is more rapid onset of the neuraxial blockade. So this leads to decreased inhalational agent requirement, and there are more chances of the local anesthetic toxicity due to increase in vascularity. There is increase in the gastric fluid volume and rise in acidity of the gastric fluid. Due to the effect of progesterone, there is decreased competency of the lower esophageal sphincter. Therefore, these patients, they are at increased risk of aspiration, and all pregnant women should be considered as full stomach. So this is the pictorial view of the physiological changes of pregnancy. So coming over to the anesthesia part, anesthesia in parturient. Due to the altered maternal physiology and the altered response to anesthesia, there is decrease in MAC, as I have already discussed, increased sensitivity to the neuraxial agents. There is decreased plasmacholinesterase level, which leads on to the variable effect of the succinylcholine. There is decreased protein binding, leading on to the free level of the drugs in the plasma, and limited drug information in parturients as available. So the goals of anesthetic management are to enhance the quality of anesthetic care for obstetric patient, improve the patient safety by reducing the incidence of complications like hypoxemia, hypotension, acidosis, and prevention of the supine hypotension syndrome, and to increase the patient satisfaction. The rate of cesarean delivery has dramatically increased in the past. And this is one of the most common surgical procedure done in the obstetric patients. So as more patients become high risk, anesthetic challenges also increase in cesarean deliveries. The current level of safety of cesarean delivery has improved due to dynamic changes in the training and practice of obstetric anesthesia, use of high fidelity simulators for teaching and training of the PG students, and widespread use of neuraxial anesthesia. The Royal College of Obstetricians and Gynecologists, they have divided the categories of cesarean section into 4 categories. Like category 1 is emergency cesarean section, when there is immediate threat to the life of the woman or fetus, and the decision to delivery time interval, it should be 30 minutes. Example of these are when there is acute fetal distress or fetal bradycardia, there is cord prolapse with bradycardia, suspected scar dehiscence or uterine rupture, antepartum hemorrhage with hypovolemia or failed instrumental delivery. Then second category is urgent, where there is maternal or fetal compromise, but that is not immediately life-threatening. The decision to delivery time interval is 75 minutes. Examples are cord prolapse with normal fetal heart, malposition in labor, and antepartum hemorrhage but without hypovolemia. Then third category is scheduled cesarean delivery, where there is no maternal or fetal compromise but that needs early delivery. Examples are failure to progress with no evidence of maternal or fetal compromise, early labor in a woman scheduled for an elective cesarean delivery, large for gestational age or breech presentation, failed induction of labor, preeclampsia, or any other indication as determined by the obstetrician. Then fourth category is elective cesarean delivery, where the delivery is timed to suit women and staff. This is the planned elective cesarean delivery. These are the practice guidelines for obstetric anesthesia, which were given by American Society of Anesthesiologists Task Force on Obstetric Anesthesia, and these guidelines were published in 2016. Where they have highlighted upon the pre-anesthetic evaluation and prevention, preventing the complications, choice of anesthetic technique, which can be spinal, epidural, GA, or combined spinal epidural, post-operative analgesia, and effect of the anesthetic drugs on the fetus. So coming over to the pre-anesthetic evaluation for cesarean section, focus history to be taken, focusing on the maternal health, anesthetic history and obstetric history, general physical examination, including the baseline vitals, including heart rate and blood pressure, systemic examination, detailed airway assessment is to be done so as we have to be prepared for the difficult airway. Examination of the site of the neuraxial blockade is to be done for any infection or deformity, recognition of any significant obstetric or anesthetic risk factor, and there should be proper communication between obstetrician, anesthesiologist, and other members of the multidisciplinary team. So, in addition to the routine investigations like hemogram of the patient, routine platelet count is advised according to the patient history. For example, in patients with preeclampsia, on physical examination and depending upon the clinical signs of the patient. Routine blood cross match is advised according to the patient history in patients with anticipated hemorrhagic complications or depending upon the clinical signs and institutional policies. So blood should be arranged for anticipated hemorrhagic complications like in patients presenting with placenta previa, placenta accreta, or when there is history of the previous uterine surgery. Fasting guidelines are to be followed as 6 to 8 hours for solids, 4 to 6 hours for fluids, and 2 hours for clear fluids. And peri-anesthetic recording of the fetal heart rate patterns is to be done before and after the neuraxial blockade. Aspiration prophylaxis is very, very important, which can be done by following the proper fasting guidelines. H2 receptor antagonists like ranitidine or pantoprazole 40 milligram can be given in addition to the prokinetics like metoclopramide. IV access and fluid bolus in the form of preloading or co-loading. Avoid glucose-containing fluids. And left lateral tilt with wedge under the right pelvis is to be maintained. Routine monitors like ECG, non-invasive BP, pulse oximeter, and fetal monitoring is to be applied. And if the case is to be done under GA, then ETCO2 nerve stimulator and temperature probe are to be applied. So to prevent complications, aspiration prophylaxis as discussed, and detailed airway assessment is to be done, and the difficult airway cart is to be kept ready, including all sizes of blades, smaller endotracheal tubes, stellate, bougie, video laryngoscopes, and supraglottic airway devices. These are very important for in the armamentarium of anesthesiologist. Maternal hypotension is to be prevented at all cost as it affects the fetoplacental perfusion in the form of IV fluid preloading. Preloading is to be done with the ringer lactate solution or co-loading. Left lateral tilt is to be maintained, and IV ephedrine or phenylephrine can be given. Phenylephrine is better as it has improved fetal acid-base status. And safe practice for placement of the neuraxial blocks, use of pencil point spinal needle instead of cutting bevel to prevent post-dural puncture headache. So the choice of anesthetic technique depends upon the anesthesiologist judgment, obstetric or fetal risk factor present, and the patient preferences. Neuraxial techniques are always to be preferred over the general anesthesia techniques. Use small gauge pencil point spinal needles to avoid post-dural puncture headache. For urgent cesarean delivery, an indwelling epidural catheter, which has been put previously for labor analgesia, may be used as an alternative to initiation of spinal or general anesthesia can be given. GA is preferred in some cases like when there is profound fetal bradycardia, there is ruptured uterus, there is severe hemorrhage or severe placental abruption, umbilical cord prolapse, and preterm footling breech presentation. So various options which we have in regional anesthesia, these are spinal anesthesia, epidural anesthesia, combined spinal and epidural anesthesia. The main advantage of spinal anesthesia are that this technique is easy to perform with rapid onset, single shot technique. It causes profound and dense neural block. And main advantage is that there is ability to maintain a wakeful state of mother. Hence, mother can enjoy the experience of delivery of baby. And this is the technique of choice for uncomplicated elective cesarean sections and in many emergency cesarean sections. Various drugs which can be used for spinal anesthesia are hyperbaric bupivacaine. Dose is 9 to 12 milligram can be given. Hyperbaric and isobaric bupivacaine can also be used. But with isobaric bupivacaine, there is slow onset of block. And various opioid adjuncts, they can also be used to improve the quality of intraoperative block and postoperative analgesia. Various adjuvants which can be used are fentanyl, sufentanil, diamorphine, and morphine. Diamorphine is not readily available in our country, and we have to be cautious when we are giving morphine, because it can lead on to maternal and fetal respiratory depression in the postoperative period. So these are various kind of needles which can be used. These are Quincke, known as cutting. These are cutting type of needles, and pencil point needles like Whitaker and Saprote, which are preferred over the cutting needles to avoid post-dural puncture headache. Now, sometimes we see that there is failure or inadequate spinal anesthesia. This diagram is showing us the exact hole position for the pencil point spinal needle during the intrathecal administration of local anesthetic solution. Like in this diagram, as we are seeing that this hole is into the subarachnoid space and there is free flow of the drug. When the position of the hole is like this, some amount of drug is going into the CSF and some amount is going into the epidural space, keeping on giving the patchy effect. In this diagram also, some amount of the whole of the amount of drug is going into the epidural space, so the spinal effect of spinal anesthesia will be not present in this needle position. So the potential complications of spinal anesthesia are hypotension, which occurs in 80% of the patients without prophylactic measures. Headache can occur, backache, nausea, and vomiting, which is secondary to the fall in BP and use of narcotics. Neurological damage can occur, but this is very rare, and anaphylaxis is also very rare complication. Hypotension, it occurs in 80% of the patients without prophylactic measures. The BP should be maintained up to 90% of the baseline values. Preventive measures include fluid administration, left lateral tilt is to be maintained, and use of the agent like ephedrine or phenylephrine. It is recommended to start phenylephrine prophylactically as an IV infusion immediately after the spinal is administered. It is to be started at 25 to 50 microgram per minute and titrated to effect according to the international consensus guideline for spinal-induced hypertension. Phenylephrine has got a better fetal acid-base status, so this is the agent, or it should be preferred in obstetric patients with hypertension. It is more potent than ephedrine by a factor of 80 for equivalent maternal blood pressure control. This is the meta-analysis of ephedrine versus phenylephrine for the management of hypertension during spinal anesthesia for cesarean section, in which they have shown the phenylephrine to be a better agent as regards to the fetal acid-base status. Various uterotonic agents which can be used are first-line drugs are oxytocin, which is to be used in the doses of as bolus 1 international unit in elective cesarean delivery, followed by infusion of 2.5 to 7.5 international unit per hour, while in intrapartum cesarean delivery, bolus is to be given 3 international units, followed by infusion of 7.5 to 15 international unit per hour. If inadequate effect after 2 minutes, then further bolus of 3 international unit can be given. And carbetocin is also the first-line drug, which can be used up to 100 microgram IV over 30 seconds. Consider second-line drugs if the inadequate effect is seen. Second-line drugs are ergometrin, which can be given intramuscularly, but it has to be avoided in patients with preeclampsia or eclampsia. Then misoprostol and carboprost, they can be given intramuscularly. Epidural anesthesia is more technically challenging. It has slower onset. It is used when already placed for labor analgesia. It is useful in parturient where a slow and controlled onset of the block is needed, but it allows the prolongation of the block if surgery is complicated. The major complications are hypotension, headache if the accidental dural puncture occurs, transient backache, urinary retention, and unintentional spinal injection if it occurs. Then intravascular injection of the local anesthetic due to the increased vascularity of the epidural venous plexus, then chances of neurological damage and infection. Combined spinal epidural anesthesia technique is indicated when the duration of surgery may be extended, like in patients with history of multiple previous surgeries, prior abdominal surgery, or in obese patients. In patients with significant cardiovascular problems like severe aortic or mitral stenosis or respiratory insufficiency, combined spinal epidural analgesia technique can be used with reduced spinal doses of bupivacaine. And the further extension of the block can be done with epidural anesthesia. Advantages are that studies have shown its superiority over the conventional techniques for reliability of analgesia and muscle relaxation. General anesthesia is to be used when patient refuses regional technique, and regional technique is contraindicated in certain conditions like in patients with coagulopathy, sepsis, severe hypovolemia. And emergency cesarean section when there is inadequate or failed regional analgesia, and the further delay will cause undue risk to the fetus or mother. So while giving general anesthesia, thorough preoperative evaluation including assessment of the airway is to be done. Antacid prophylaxis is to be given, as we have already discussed. Pre-oxygenation for 3 minutes in the ramped position with the left uterine displacement. It helps in increasing the functional capacity and apnea time and facilitate laryngoscopy in obese patients. Rapid sequence induction with required pressure using thiopentone sodium or propofol for induction. Etomidate can also be used in patients who are hemodynamically unstable. Followed by succinylcholine 1 to 1.5 mg per kilogram IV or rocuronium 1 mg per kilogram IV for neuromuscular blockade, and intubation with endotracheal tube of required size. So why is obstetric airway management difficult? Due to the anatomical and physiological changes during pregnancy, like if we see in airway, there is weight gain in pregnancy, which causes difficulty with positioning of the patient. Increased breast size causes difficulty with laryngoscope insertion. Increased vascularity and edema of the airway mucosa, it causes increased risk of airway bleeding and potential difficulty with tracheal intubation. There is reduced functional residual capacity, and there is increased rate of oxygen desaturation. There is increased oxygen consumption secondary to the increased metabolic demand, and leading on to increased rate of oxygen desaturation, and there is decreased lower esophageal sphincter tone and delayed gastric emptying. All these factors, they lead to increased risk of gastric regurgitation and pulmonary aspiration. This is the algorithm for safe obstetric general anesthesia pre-theater preparation, airway, in which we have to do airway assessment, fasting status. This we have already discussed. WHO planning is to be done according to the WHO safety checklist, and all the equipment for the difficult or failed intubation is to be kept ready. We have to proceed with the rapid sequence induction, optimize the position, ramping position, then pre-oxygenation to end tidal oxygen of more than 0.9. Required pressure is to be given, then give the appropriate induction agent. Consider the face mask ventilation if the first intubation attempt is failed. If there is poor view of larynx, then optimize the attempt by reducing or removing the required pressure. External laryngeal manipulation can be done, or repositioning of the head and neck, bougie or stillet can be used. And if the first intubation attempt is failed, then second intubation attempt, we have to use the alternate laryngoscope, or we have to remove the required pressure. Remember that if the first intubation attempt fails, you have to immediately call for help of the expert. Effects of anesthesia on fetus. We have to avoid hypotension, hypoxia, acidosis, and hyperventilation, and the time should be limited between uterine incision and delivery to less than 3 minutes. Infants exposed to GA have lower APGAR scores at 1 minute, but there is no difference at 5 minutes as compared to the neuraxial anesthesia. There is no significant alteration in neurobehavioral scores with regional techniques. Now, supraglottic devices, they have proved to be a boon for anesthesiologists' armamentarium in patients with obstetric anesthesia. The various devices which can be used, they are laryngeal mask airway and second generation supraglottic airway devices. In these devices, we can use LMA ProSeal, which incorporates a second tube which is intended to permit the continuity with the gastrointestinal tract and isolation from the airway, and it minimizes the gastric insufflation during positive pressure ventilation. Second generation supraglottic airway devices, they have been incorporated in the obstetric difficult airway algorithm. And various disposable versions of ProSeal like LMA Supreme and Embu or again, they can also be used and they should be kept handy. Safe use of supraglottic devices requires proper patient selection, proper airway assessment like mouth opening should be adequate and adequate fasting status should be confirmed, and anesthesiologists with proficient regular use of LM. These are All India Difficult Airway Association 2016 guidelines which are given for the management of unanticipated difficult tracheal intubation in obstetric patients. And these are published in Indian Journal of Anesthesia. Step 1 is on laryngoscopy and tracheal intubation. If we are unable to intubate the patient at first attempt with direct or video laryngoscopy, we have to immediately call for expert help. Nasal oxygenation is to be continued with oxygen flow of 15 liters per minute. And one more attempt at intubation is to be taken only if the saturation is more than 95%. We have to release the partial or complete release of the required pressure if the mask ventilation is inadequate, and optimize the position of the patient during the second intubation attempt. When the 2 attempts of intubation are failed, then this is failed intubation and we have to go to the plan B, that is insert the supraglottic airway device to maintain oxygenation. Remember that while putting supraglottic airway devices or whatever airway manipulations we are doing, we have to continue with the nasal oxygenation using oxygen flow at 15 liters per minute. Maximum 2 attempts are to be given for the supraglottic airway devices. If it is successful, then we have to proceed with the cesarean section. But if we fail with the 2 attempts of supraglottic airway devices and there is failed ventilation, then we have to resume the face mask ventilation but with continued nasal oxygen using oxygen flow at 15 liters per minute. If we are not able to ventilate with the face mask, then there is complete ventilation failure. We have to ask for the additional help. Then we have to proceed for the emergency cricothyroidotomy. If we succeed in emergency cricothyroidotomy, we have to give jet ventilation through the cricothyroidotomy. And if the cesarean section is not an emergency, we have to consider awakening the mother and to plan for the intubation in the next sitting. If the oxygenation is failed even through needle cricothyroidotomy also and the patient goes into cardiac arrest situation, then advanced life support is to be given and we have to do the perimortem cesarean delivery. Complications after general anesthesia are one of the major complications is awareness under GA, nausea and vomiting, nerve pulses, pain after surgery and emergence delirium. Patient may have cognitive defects, residual neuromuscular paralysis and residual sedation. For post-operative analgesia, multimodal analgesia is to be given, which includes regular administration of acetaminophen alone or NSAIDs like diclofenac or ibuprofen with opioids. Ultrasound-guided transversus abdominis spleen blocks are also effective. Then infiltration of the incision site with long-acting local anesthetics can also be used. Management of the emergency cesarean like category 1 cesarean delivery. In this, general anesthesia with rapid sequence induction technique and cricoid pressure is the potentially useful technique in category 1 cesarean delivery, as this is the likely the quickest method to facilitate safe delivery of the baby. Then I want to mention the technique of rapid sequence spinal. This technique was introduced in 2003. In this, what is done is that delegate the activities like IV cannulation is to be done by the one person, and who will also be applying. Then one task is to be given for applying the patient monitors. No touch technique for spinal needle insertion, like only wear mask and cap and sterile gloves without sterile gown. Single wipe of chlorhexidine solution or povidone iodine can be done. Then spinal drug preparation by increasing the dose of hyperbaric bupivacaine. Opioids are to be omitted. Only one attempt at spinal placement unless obvious correction allows a second attempt. Commence the surgery on a rising block when the block has been achieved till T10. Like, we don't have to wait for the block to reach the height of T4. Start the surgery when the block reaches T10. But be prepared to administer immediate GA if spinal is inadequate. This is the flow chart how to proceed for the rapid sequence spinal anesthesia. We have to pre-oxygenate the patient pre-oxygenate the parturient during the procedures all the time. We have to be prepared to convert to general anesthesia, deploy the other staff for intravenous cannulation and monitoring. No touch technique is to be followed. Gloves only with glove packet as sterile surface or equipment. Prepare skin with alcoholic povidone iodine. Only one coat is sufficient. Consider the increased dose of hyperbaric bupivacaine, 0.5% up to 2.5 to 3 ml. Fentanyl can be added if it is readily available, but if it is not available, we don't have to wait. Local infiltration is not mandatory. Only one attempt at spinal unless obvious correction allows a second. If necessary, start surgery when the block reaches T10. Now, another option is if functioning epidural catheter is present, if it is already been inserted during labor analgesia, then dosing with a fast-acting local anesthetic solution such as 2% lignocaine with or without 75 to 100 microgram fentanyl has a mean time to be ready for skin incision of approximately 10 minutes. In an emergency, the top-up can be initiated in the delivery suite only with the anesthesiologist directly observing and monitoring the patient. Addition of preservative-free sodium bicarbonate further reduces the onset time. So to conclude, practice guidelines, they are systematically developed recommendations to manage the analgesia during labor and anesthesia for surgical intervention, care of the parturients. Neuraxial anesthesia for cesarean delivery is associated with lower maternal and neonatal morbidity and mortality as compared to the general anesthesia techniques. Prophylactic measures to avoid spinal-induced hypotension are important to maintain uteroplacental perfusion. Early communication between the anesthesiologist, obstetrician, and pediatric professionals regarding labor status and patient-specific considerations creates an optimal environment for safe maternal and neonatal care. Thanks for patience.
Thank you, Dr. Veena, for covering the whole topic so well. I'm sure the students have benefited. Maybe we could take the questions at the end of both the lectures. Would that be okay, Veena? Right. So we'll start the second lecture, that's on labor analgesia by Dr. Swati. And welcome, Swati. Welcome to the APPEC2023.
Thank you,
can I have her CV? I know that she's from Patna.
Yes, ma'am.
She's an additional professor in the IGIMS Patna.